Okay, we're back with LLSA 2021. The article is titled Managing Patients with Transient Ischemic Attack by Edlow. And Salim, I'm glad this article's in here because TIAs are something that I worry about, but then clinically, sometimes I feel like I've brushed them off. Which ones do I need to worry about? Which ones do I need to work up? Do we admit them? Do we send them home? It's always been a bit confusing for me, and so I'm hoping this is going to shed a little bit of light on that.
Yeah, I mean, I think of TIAs kind of like the non-STEMIs of stroke. I
Mm-hmm.
mean, we just kind of like, oh, they got a non-STEMI, they're not going to the cath lab, we'll just medically manage them. And it's kind of the same thing with TIAs. It's like, oh, they probably had a TIA, they probably need some imaging, start them on some aspirin and let them go. But it's actually a lot more nuanced. And I think uh, Edlow did a nice job kind of going through this review. So, the original definition was focal neurologic deficit from a vascular cause lasting less than 24 hours. That's the old definition. The new definition now is transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. And the reason the definition has changed is because the imaging modalities we have, the therapies that we have available, and our understanding of stroke have kind of changed over time, especially in the last few years with some of this like perfusion based imaging and stuff that we're doing. And that led to the new definition. And the original diagnosis was likely including patients who were actually having minor ischemic strokes, but just didn't have any significant disabling deficits. But again, with all this new imaging technology, we're able to find these patients and really do a much better job using a better tool to tell us like, no, they haven't had an infarct, or no, they have had an infarct. Now, the median duration of time of the neurologic deficit for TIAs was about 14 minutes, according to this review. And for carotid events, it was about 8 minutes for vertebrobasilar events. And they quote a study that had like 1,300 patients with TIAs. Now, if the patient's asymptomatic at the time they come to the ED, the diagnosis is usually based completely on the patient's history and their description of symptoms, which reminds me a lot of syncope. A lot of it is like history based. We don't really get very good, like, we don't have a gold standard tool.
Yeah, and Salim, that kind of makes sense when you're giving me median lengths of symptoms of 14 minutes and 8 minutes. A lot of these patients probably might not be having their symptoms actively when I'm actually seeing them. And so a good reminder, like TIA, it's transient, and that 24 hour number, really, it can be a lot shorter. And like you pointed out, the history is really where the money is.
Yeah, I mean, and that's exactly it. Oftentimes these people will come and say like, "Oh, I had this for like 30 minutes. I had this weird thing and then now it's gone." And so you have to really spend a little bit of time trying to get that information out of them. It's not like there's a diagnostic test that's going to tell us at that moment. Now, the second group is like if the patient comes in and they're actively having their TIA, they have neurologic deficits at the time of ED evaluation, then you treat these patients like they're having an acute stroke and you work them up like they're having a stroke, and you get them to the scanner as quickly as you can and see if they're candidates for alteplase or tenecteplase, whatever you're using at your institution. Now, they make a point in this paper that is kind of not surprising to me, but they say the misdiagnosis of TIA in the ED could be as high as 60%. And in one study, they say 41% of patients given a diagnosis of TIA in the ED ended up having a different diagnosis altogether when they followed up with a stroke neurologist. And I don't think this is because we're bad at what we do. I think it's just we don't have as much information. And a lot of the follow-up is after imaging and after testing, and a lot of other things have been done. So I think it's like looking at it in a retroscope as opposed to prospectively the way we get these patients. Now, the other thing that's interesting is even if you ask stroke trained neurologists to tell you TIA versus not TIA, even they disagree about
Yeah.
what the actual diagnosis is. So this isn't specific to like, oh, ED docs are bad at finding this. I just think it's that difficult a diagnosis to make because it's so subjective and so based on history. Now, there's lots of mimics out there, right? Things to kind of consider. Not everything that comes in with neurologic symptoms is a TIA or a stroke. I mean, these could be complex migraines. They could be seizure with a paralysis known as Todd's paralysis. It could be hypoglycemia. There's lots of other things that are out there, and they have a table that has like a list of other things to consider in the differential. Now, some pitfalls in TIA diagnosis that I think are important is that transient global hypoperfusion symptoms leading to syncope, loss of consciousness, generalized weakness, vague lightheadedness, or altered mental status, those sorts of things are usually rare in terms of being due to TIA. These kind of vague symptoms is not typical of TIA. Now, isolated episodes of vertigo, this is a tough one. Vertigo is always one of those like, oh, I hate it when they come in and they say dizziness. Because, is it a benign peripheral thing or is it a central cause? Well, the thing to remember here is with vertigo, it accounts for about half of TIA events. That's 50%, 1 in 2. And they usually occur in 48 hours prior to the posterior circulation strokes actually happening from a vertebral artery stenosis or occlusion. Posterior circulation TIAs also have worse outcomes than anterior circulation TIAs. So that's another reason why this is so important.
Yeah, Salim, I agree with you 100%. A vertigo patient, I'm doing a very, very detailed workup in terms of my physical exam and trying to figure out, fleshing out that vertigo because I've missed it so many times and I've found it on imaging. But the other thing that I think is really important that you pointed out is, yeah, there's these non-specific symptoms and, syncope and that list that you showed before. And now we're having a patient who's coming in not with actual physical exam findings. We have to flesh out these specific symptoms based on their history. And so it takes me a moment, but I always think about, okay, I'm thinking about a stroke or an area of the brain where this TIA is affecting, and I'm really going to hone in terms of the unilaterality of their symptoms and the minutia of the details of what exactly were you having. If it's just like dizziness and fatigue and stuff like that, that's non-specific. And when it's really specific to some part of the cortex, that's when I'm like, okay, I cannot rule out TIA and I need to move forward with this workup. And so it's really important in terms of putting on our physician hats and getting that history and tying it into what we think would actually be going centrally.
Yeah, I mean, I agree. I mean, obviously, if there's a focal neurologic deficit that's in conjunction with arterial supply to the brain, then yeah, obviously we're dealing with a central thing. The problem I find with these patients is that oftentimes that we're dealing with non-medical people and we're asking them very specific medical questions and they're very vague in the way that they describe because they don't know what those key buzzwords are that kind of trigger our brains. And that's, I think, what makes this kind of hard. But, you're right. Doing a good focused neurologic exam, like looking at the cranial nerves, actually, it's probably important to look at that. Make sure that, their extraocular vision is okay, that they don't have field cuts. I think these things are all kind of important things that we can actually do on exam if they're still having the symptoms, which, as we said earlier, oftentimes they don't. So, there's a nice table in this review article where he talks about in general TIAs present with what he calls quote unquote negative symptoms where neurologic function is diminished or absent, right? TIA mimics usually present with positive symptoms. So things that the patient will tell you. Now, one exception to this rule, which is kind of important to remember, is that high grade carotid stenosis, you can actually get a positive symptom, which is involuntary limb shaking. And that's been documented to occur. But otherwise, in general, TIAs tend to have more negative symptoms, as you can see in the table. And the mimics tend to have more positive symptoms, with that one exception. So, important pearl from the paper. As a general rule, a patient with an abrupt onset and rapid offset of a new neurologic symptom, localizable to a specific artery, is a TIA until proven otherwise. And I think both of you and I have said that. So this is like the third time people are hearing us say that. But doing a physical exam is important. Yeah, I kind of rolled my eyes when I got to this part of the paper and they started talking about this ABCD squared score. I mean, this was something that's been like hammered into me since I was like a resident. And it's kind of fallen by the wayside. And actually, the good news is, or the bad news, depending on how you look at this tool, ASAP actually doesn't recommend using this score for safety and for discharge. And I think for good reason. One of the important downfalls of this ABCD squared score is it doesn't accurately identify patients with large vessel stenosis. And we know that patients with large vessel stenosis or large vessel occlusion, we now have mechanical thrombectomy and that we can do for these patients and multiple randomized clinical trials. This tool misses that population. And the other thing it misses is patients with atrial fibrillation. So potentially cardioembolic events. And so both these groups of patients have very specific interventions because for the cardioembolic events, we're talking anticoagulation, right? We're not talking just antiplatelet medication anymore. It's not just start them on aspirin. There's actually very specific treatment modalities we can use. And this score completely misses those two populations. Now, I think most of us have started doing this, and I suspect we're going to see more and more of this as time goes on. But adding specific CNS imaging, such as diffusion weighted MRI, CTA or MRA, perfusion based imaging, carotid ultrasonography, these can all help improve risk stratification. I guess the question I have, and the author brings this up in the paper, is that do we need to do all this in the ED or can it be done as an outpatient? And I find that, at least in the United States, I would be hard pressed to be able to get this done in an expedited manner outside of the ED. And so most of the time I'm doing this workup either in the ED or they're getting admitted for observation to get this workup done, not because it changes outcomes, but because I just can't get it done any faster without doing it that way.
Salim, my experience has been similar to yours in terms of getting all this imaging, this kind of trifecta of imaging in the emergency department has been difficult historically. And that's, we used to be kind of stuck with just CT, and that kind of brought some of that diagnostic uncertainty. The nice thing is, as you point out, is look, we have this imaging. It's very helpful. While I don't want to do it in the emergency department, I do have my neurologist on board now, realizing like, yeah, we need this. This is important to our workup. And we've almost been able to have a partnership where we take it out of the emergency department. We do it in like a OBS area or a TIA workup area where I just get my neurologist involved early and we work up that patient, not necessarily right where I'm working. It could be rapidly in those OBS areas or really in an outpatient neurologic setting. And we've had a great partnership with them.
I mean, so much so they're on board that almost having a risk stratification score almost seems like a moot point because you're just not going to be able to get this workup done any faster. If you're thinking TIA or some kind of central process, they're going to get this imaging done. And so it's almost like silly to even have a risk stratification score. It identifies so few people that are low risk. I mean, it's that middle risk group that we're worried about, right? Which is the chunk when you look at, using a score like this. And actually, if you look at some of the original studies, 70% of people fall in this middle risk group. Well, this score is not going to be that helpful. We know what to do with the high risk people. The low risk people, it's going to be so minimal. It's that middle risk group. And I think that's why we don't see a lot of people advocating for these scores. All right, so let's talk about diagnostic testing. So the goal obviously is to identify treatable causes of TIA. And we alluded to this at the beginning of this talk, is that atrial fibrillation is going to account for about 20 to 25% of TIA cases, according to this review. And things we can do are obviously EKG, cardiac telemetry can also be helpful in identifying that. And then MRI with diffusion weighted imaging is preferred, according to this author, but non-contrast head CT has a yield of about 1%. Again, I don't know how many of us are really able to do MRI diffusion weighted imaging in the ED. And so I think most of us use what we can, which is going to be CT, CTA, and then all the perfusion and diffusion weighted imaging kind of gets done in an observational time frame. But I guess that's going to be dependent on the system you work in. But just know for this review paper, the recommended study is MRI with diffusion weighted imaging is the preferred modality. Now, early identification of high-risk patients with symptomatic carotid stenosis of greater than 50% is also important because this could allow for like planning for urgent revascularization. And in one study, large vessel disease caused about 10.6% of TIA. So that's about 1 in 10. And accounted for 40% of recurrent neurologic events in the following 48 hours. So that's not an insignificant number, and definitely something we should keep in mind. He goes on to say that ACEP recommends vascular imaging when feasible and cites that there's no evidence that performing vascular imaging in the ED improves patient-centered outcomes, which is what we've been talking about for the last few minutes. But the author actually disagrees with that statement and says that in his opinion, vascular imaging is the single most important test that we do. I tend to agree with the author on that. I think that, again, neurologists are on board with this. I think systems understand how important this is. We realize that we work with limited resources. And so I think this is what most people are doing despite the statement. And then certainly you can do echocardiography to look for thrombi in the atria from atrial fibrillation to see if they're having cardioembolic events. But I think that's going to be only in select patients. It's not going to be everybody who's coming through. So this is the big pearl. Suspected TIA should have neuroimaging. In an ideal world, MRI with diffusion-weighted imaging is going to be the study of choice. But you can do CT angiography. It's an acceptable but inferior alternative. And I think that's what most of us do in practice. But for the purpose of this review article, MRI is the ideal study.
And translating this to the clinical setting, Sal, is like you said, right? I don't have an MRI diffusion weight imaging that is available like that, but I do have CT. And so I'm going to do my EKG for AFib. I'm going to do my CT with and without contrast with the angiography part, and then make my decision. And if I'm still thinking TIA, which I usually am if I've done that imaging, I'm talking to my neurologist and we're setting up that MRI stuff outside of the emergency department.
Exactly. Now, treatment and disposition, this is where it gets kind of interesting. So there's a couple of things that are pretty black and white, and I agree with, and I think makes a lot of sense. So this paper recommends admitting anybody with suspected TIA who has a cardioembolic cause or large vessel disease as the etiology of their TIA. And for good reason, because with cardioembolic disease, there's anticoagulation, as I've said. And with carotid disease, there's revascularization that can occur during the hospitalization. So those both have like a very specific treatment. Now, the options for revascularization, that's not something we're deciding in the ED. That's usually the vascular surgeon that's making that decision. But in the paper, he says they could have carotid endarterectomy, or sometimes they'll even just do stenting. Now, where this evaluation should occur is what we've spent a lot of time talking about. And I suspect, again, each system is going to be different. If you have a next day clinic that's able to get all this stuff done, by all means, discharge the patient with that follow-up. I just don't happen to work in that type of system. And I think most of us in the US don't work in that type of system. And so what's more important, and what the author emphasizes, is how fast the evaluation occurs is way more important than where it occurs. And I think that's an important point. And I think that's what most of us try and do in the systems that we work in. Okay, this one is, again, no brainer. The author says, simple recommendation, unless there's a contraindication, give aspirin. I think most of us are doing this. We know the benefits of giving an antiplatelet medication such as aspirin for these patients in suspected TIA and reducing subsequent stroke and neurologic deficits. He mentions in this paper that some experts recommend giving aspirin before any brain imaging. I don't know. That's a bit cavalier for me, because what if they have a big bleed and then I've given them aspirin ahead of time? You just kind of look not intelligent when you do that. So yeah. I don't think waiting the 30 to 45 minutes to get the imaging and then give them the aspirin is that big a deal.
Yeah, and the beauty is that imaging, it no longer takes hours. It happens relatively quickly.
Exactly. And then this is a table of all the kind of current recommendations with the level of evidence. Again, aspirin being kind of the highest. If they have an allergy to aspirin, you can certainly do clopidogrel as an acceptable second line. And then they kind of go through and talk about some of the other agents and dual antiplatelet therapy. And you can see the levels of evidence in this table. I'm not going to read a slide that people can just read themselves. Now, this pitfall slide is a bit long. It's got a lot of words, but kind of important from this review article. So what are some of the reasons you would consider admitting a TIA patient? Well, if they're having multiple TIAs, they're having a stuttering kind of episodic state of TIAs, crescendo, where it's increasing in frequency in a shorter amount of time. These would all be reasons you'd want to admit the patient. TIA while receiving anticoagulation, severely abnormal vital signs like hypertensive emergency, for example, and then patients with carotid bruits or new cardiac murmurs, prosthetic cardiac valves, all would require and should be considered for admission. Atrial fibrillation and other EKG findings suggesting potential embolic source. Again, we said anticoagulation is a directed therapy for that, so those patients would get admitted. In this article, they also state if they're having a TIA and they're pregnant, they should get admitted. Logistic issues with getting outpatient evaluation, which I think is the biggest one most of us face. And then significant medical comorbidities making hospitalization a better option. For example, if they're stuck in a wheelchair, they have really bad CHF, their diabetes is out of control. These would all be reasons, again, to consider for admission.
So when I translate that last slide, clinically, it makes sense, right? I've got my non-complicated TIAs where I'm still going to do my expedited workup and discuss it with my neurologist. But then the people on that list, while it's long, they make sense. These are patients that are either clearly need an intervention done now, or they have something that's going to be complicating their workup where I'm not just going to sit on it for a little bit longer than I would for the uncomplicated ones.
Yeah, I mean, as you said, it makes intuitive sense. It's not like a list you have to memorize. It's just like practicing good clinical medicine. These are patients that are either having increasing frequency or severity of their symptoms, or there's something else that makes the situation more complicated than it already is. And in those scenarios and directed therapy, those would all be reasons why you would admit somebody to kind of help expedite that and get that therapy initiated. So couldn't agree more.
This is Hippo Education.